Hello, this is Professor Christian Holscher, and today I will report about the two large phase 3 trials that tested semaglutide in Alzheimer patients. And we were told that the trials actually had failed. However, is this really true? Well, let's have a look at the data that they presented. So semaglutide is a drug designed to treat diabetes. It's on the market for diabetes and weight loss. It's a member of the GLP-1 type drug family. And I and other scientists have conducted experiments in cell culture and animal models of disease that showed that semaglutide does have some protective effects. And the predecessor of semaglutide, liraglutide, actually showed protective effects in a phase 2 clinical trial in Alzheimer patients. And we have published this paper. You can download it for free. So here's the study design. Two large phase 3 trials with sufficient patients. The total duration was 156 weeks, but there was an intermediate readout at week 104. So you can see that there were a lot of patients at the starting point, and 1,855 for the Evoke and 1,953 patients for Evoke Plus. The oral formulation of semaglutide was used, a once daily pill that people have to swallow. Then the dosage was slowly ramped up from 3 to 7, then to 14 milligram daily, even though some patients didn't really stay at the high dose because of side effects. And the total duration was 156 weeks, which is a long period. And they presented the results of the readout at week 104. Then they had a number of primary and secondary readouts. So the primary endpoint was the change in the CDR-SB score, and then other secondary endpoints that I will describe in more detail. Here's a list of the test batteries that they used, like the ADAS-Cog13, which is a very good test battery for testing cognition in Alzheimer patients in such clinical trials, and other tests as well that I will describe later in more detail. Just at the beginning, we have to look at the study's design and have to say that the drug certainly wasn't the right choice. Semaglutide has been designed to stay in the blood to treat diabetes for a long time, for weeks, so it doesn't really get into the brain easily because it stays in the blood. The oral formulation has a limited availability of the drug, and the choice of the primary endpoint as the change in the clinical dementia rating, sum of boxes, was not a good choice, as this test battery is really not considered to be very precise or very detailed. The ADAS-Cog13 tests and the ADL test batteries are much better. They're proper cognitive tests that should have been chosen as a primary readout. Here, just to show that GLP-1 type drugs do not always enter the brain, cross the blood-brain barrier. This is a study where drugs were radio-labeled and injected peripherally. And then 1 hour later, they looked at the drug levels in the brain, and they could see that semaglutide, that's on the right side, doesn't really enter the brain after 1 hour. It's very slow in getting into the brain. While other drugs like exenatide or lixisenatide, they can enter the brain better. So then let's look at the results. So they have been presented at the CTAD conference in San Diego, and they only presented the results of the week 104 intermediate readout, though in total data were actually collected up to week 156. But they didn't analyze those data, which is very strange. It's not clear why they didn't analyze the data that they clearly have. So this is the primary readout. As I said, this is not a good choice of testing cognition. It's not really designed for that. And you can see at week 104, there is no difference between groups in the EVOKE trial and in the EVOKE Plus trial. So in this test battery, there was no difference between group. And as I said, the later 113 and 156 week data had not been analyzed. Then a better test is the ADAS, ADCS, ADL. And here we see that at week 104, again, there is no differences between groups in the EVOKE and an EVOKE Plus trial. But if you look at the later time points, you can see that there is a separation between groups. Let's have a look at that in more detail. The later time points had not been analyzed statistically. But if we look at it in an enlargement, you can see in the EVOKE trial at week 156, there is a separation of groups. And in the EVOKE Plus trial, it's even clearer that at week 130 there's a clear separation between groups, and week 156 there's still a separation. Importantly, at week 130 in the EVOKE Plus trial there was no overlap of error bars, and there were a large number of patients, over 800 per group. So this tells us that this is a significant outcome, statistically significant, but it hasn't been presented at the conference. Then the week 156 data, in both trials they look significant too, but we need to test that with the proper tools. Then they presented other secondary outcomes. As you can see, they didn't show them in a very clear fashion. All the graphs are very small, and they only analyzed week 104 data. So let's go through this one by one. The ADAS COG13 results. Again, that's a good test, a much better test than the use for the primary readout. And here we see that at week 104, there is no difference between groups, but at week 156, there clearly is between the drug group and the placebo group in both trials. Again, the separation seems to be quite clear, only very little overlap of the error bars. Here, at this time point, there were 280 patients in the drug group and 283 in the EVOKE trial. For the EVOKE Plus trial, the numbers were similar. So this suggests that this is a statistically significant result, but the data had not been analyzed. Then the Montreal Cognitive Assessment Score, again, no difference at week 104, but if we look at the EVOKE trial, you can see a separation of groups at week 156. This looks significant, but the data had not been analyzed. Then the mini-mental state, again, there is a separation in the EVOKE trial at week 156. the mini mental state examination is actually a rather simple test. It's not really designed, it's not sensitive enough to see shifts over time or differences, small differences between groups. However, there seems to be a difference between groups at week 156 in the EVOKE trial. So again, why were these data not analyzed? Furthermore, there has been an analysis of how many patients converted from MCI, mild cognitive impairment, to full dementia, Alzheimer's disease. And we are told that there is no difference between groups. And these data are EVOKE and EVOKE Plus combined. However, when we look at the final section of the graph, we can clearly see a difference between drug group and placebo group, with the drug group staying at 75% conversion, but all of the patients in the placebo group converted to Alzheimer's disease. There was a sub-story where they analyzed CSF fluids for biomarkers. They took samples at week 78, and it's just a subgroup of patients. And when analyzing these biomarkers, they found that some of the AD relevant biomarkers were different, were lower in the drug group. So there clearly was some effect in phosphorylated tau and neurogranin. It shows that the drug did have some effect. It shifted the levels downwards as you would want it to be. The effect was rather limited, and this again suggests that the drug is not the correct drug to choose. It doesn't really get into the brain very well. So in conclusion, the trials were well designed and powered, and the duration was long enough for an Alzheimer trial, but the drug chosen was not great. You should choose a drug that can enter the brain better. Again, the oral formulation was not a good choice. However, I think I have convinced you that semaglutide did show effects in some of the endpoints, and there may well be significant effects, but we don't know yet because they had not been properly analyzed. So the claim that these clinical trials were a failure are clearly wrong. And what needs to be done is that all data that are available for these trials have to be statistically analyzed, and the data must be presented in a transparent and unbiased fashion. The results of this trial and of the ELAD study that tested liraglutide in Alzheimer patients clearly support the idea that GLP-1 type drugs are neuroprotective. However, those drugs are not designed to enter the brain, so we really need to run tests with other GLP-1 type drugs that can enter the brain much easier. Okay, thank you for watching. And if you want to know more, I have a website, and you can download scientific papers that report effects of semaglutide in animal models or liraglutide in the phase 2 clinical trial. And thanks again for watching. Bye-bye.